All right. Benu, Kurt, thank you so much for giving me the opportunity of coming and being with you today. This is what I want to cover. I want to start by introducing a case to you. It's actually a fresh case from yesterday in the HPI. Then I'm going to talk about what is the problem of cardio-oncology. I'm going to talk briefly about an expert consensus that is coming down the pipeline, and then I'm going to introduce a case of radiation heart disease, and I'm going to show you what is that we published in a recent consensus. So let's start, and I want your help with this one. Like I told you, this is fresh from the oven. It's a case from yesterday. My colleague Alan Klein went to the echo lab looking for me. He told me that he had in the consultation service upstairs an 81-year-old gentleman with history of a large B-cell lymphoma that was treated with R-CHOP, who presented to the emergency room with shortness of breath. They did a pretty good job in the emergency room. They did a workup. They didn't see any evidence of pulmonary embolism. However, they noted an elevated NT-proBNP at 4,806, and they did an echo. I'm going to show you that in a second, showing an ejection fraction of 20%. Interestingly enough, this patient had history of hypertension, and as part of the treatment with the R-CHOP, the steroids gave him diabetes mellitus. So as you can see, a very unhappy ventricle, global dysfunction, calculated ejection fraction in our echo lab of 20%. And then the question that I have for you is, what is the most likely explanation of his cardiomyopathy? And I want show of hands. Who says his hypertension, coronary artery disease, chemo-induced, or can't tell? And I really like the ones that pick up the can't tell, because the right answer is, although I am very inclined to think that this can be chemo-induced cardiomyopathy, you cannot tell. And you gotta do exactly the same workup that you will do for any patient that shows up with a reduced ejection fraction. The first answer is to classify these patients as ischemic or non-ischemic. And then the question is, what is the most appropriate next step? Should we take this patient to the nuclear stress lab? Who votes for that? Who votes for a cardio-oncology consultation? I don't think that that's a wrong answer. Who votes for cardiac catheterization? That is actually the right way to go, as we were mentioning. And then down the pipeline, once we confirm that we don't have evidence of coronary artery disease, then indeed we will consult our electrophysiology colleagues for the consideration for an ICD implantation, but not quite now. So let me talk a little bit about what is the extent of the problem. And I think that this is actually part of the problem, that when you take a look at the data that has been generated from the mega trials, and this is actually a very nice manuscript. This is from the Cochrane collaboration, where pretty much they put together all of the trials in breast cancer medicine. You see over here in different colors the different chemotherapy regimens. But what I want to show you is where the data is. I think that it is very compelling and this is the analysis for Herceptin, that you do have an impact in mortality. When you take a look at all of these trials together, you are reducing mortality by 43%. You have an impact in disease-free survival. You increase it by 40% when you treat the patients with these regimens. But the problem is that there is a price to pay, and the price to pay is congestive heart failure. Nevertheless, when you take a look at these figures, you will end up coming with the conclusion that the rate at which this happens is about 2.5%. The reality is that this is not what we see in our day-to-day practice. We know that this is a more frequent problem. And this is a very nice study published in the Journal of the National Cancer Institute, where they went and they addressed this issue. How is that this problem looks like in real life? Asking primary care physicians, oncologists, how many of these patients they are seeing. And let me share with you the conclusions of the study. This is rate of heart failure at 5 years, and I think that this is fairly accurate. With anthracyclines, you are going to get a rate of 4.3%. With trastuzumab only, you're going to get a rate of 12.1%. Anthracyclines and trastuzumab, and I want you to remember this figure, you are going to be getting a percentage of 20%. This is really a message that you got to take from this meeting. When you combine these two regimens, and this is probably the most frequent combination for these patients, you're going to end up with a rate of congestive heart failure of 20%. Now, we actually confirmed this data in a recent abstract presentation in ACC. We evaluated all the data from CER Medicare, and we end up coming up with the conclusion that indeed the rate of heart failure in these patients were about 16%. Now, we had this recent publication in JACC where they ask a simple question, and what if the patient that you're treating is not a young person like myself, but is an elderly lady, 65 years old or so? Well, let me show you, it's actually very sobering. When you combine anthracycline and trastuzumab, the rate of toxicity is not 20%, it's actually 42%. So think for a second, the way that I think about it is this is really an issue of public health, because this is the most common cancer in the United States, breast cancer. 1 out of every 7 women will get it. And what I'm telling you is that 1 out of every 5 young female patients will develop heart failure. And if it happens in the elderly, it's actually almost close to 1 in 3 or 1 in 2. These patients are going to be showing up in your offices. And what I want you to think when you see these patients is to remember these figures. You got to ask yourself, is this somebody that is going to receive cancer treatment? Let me get an echo. Let me think about whether this patient is already coming with risk factors, hypertension, diabetes, hyperlipidemia, coronary artery disease. You know that if they are already starting with trouble, they are not going to do well with therapy. If they are in the midst of treatment, I'm going to show you how to do it in a second. If they have received treatment, you got to think, is this somebody that has had a recent echo? Or should I order an echo? And if I see anything abnormal, like in this particular case, give us a call. We will be happy to take care of these patients. Let me share a few words about the expert consensus. I had the opportunity of being the chairman of the writing group. This is a joint effort between the American Society of Echo, the European Association of Cardiovascular Imaging, and the American Society of Clinical Oncology. It's going to be coming in the first semester of 2014. And this is how it looks. And it's going to have 5 parts. I don't have time to cover everything, but I just want to cover some important points with you. The way that we did it is we did it taking in consideration the mechanisms of toxicity. So I would like to spend a few minutes just familiarizing you at least with 2 of the major mechanisms so that you can understand really what is that is happening with the oncologists gave these medications. And I want to do it in the setting of a case. This is a real case from the clinic, 47-year-old female who presents with a diagnosis of breast cancer. She is prescribed TCH, which is the most common chemotherapy regimen, docetaxel, carboplatinum, and trastuzumab, which, as I'm going to show you in a second, is one of the offenders, followed by mastectomy. So let's talk a little bit about the mechanisms of toxicity. Before I do that, in the past, we used a term. The term was cardiotoxicity. In the upcoming expert consensus, we are using this term, and I want to make you familiar with this. It's CTRCD, and it stands for Cancer Therapeutics Related Cardiac Dysfunction. So how do we define it? We define it as this. We define it as a confirmed drop of 10 points of ejection fraction to an ejection fraction less than 50%. And we are actually not mandating just one measurement. We're actually mandating an initial measurement, then 3 weeks of lag period, and then a reconfirmation that indeed the ventricle is in trouble and that you are not just having a mistake in the calculation in the echo lab. Cancer therapeutics related cardiac dysfunction comes in 2 flavors, type 1 and type 2. Type 1 is the one that is portrayed and characterized by anthracyclines. Is when you see these hearts in the microscope, you are able to see biopsy changes. You see actually evidence of cellular death. It's cumulative dose related, and unless that you recognize it early, and I think that this is a very important message that I want to convey to you, then the damage is irreversible. So kind of like Dr. Menon will tell you in the coronary artery disease that time is muscle. Well, time is muscle also in cardio-oncology. And if you don't recognize these patients early on, then the rate of success is going to be close to 0. In contrast to that, then you have type 2. Type 2 resembles more the stoning that you describe in coronary artery disease. You don't see changes in the biopsy. It's not cumulative dose related, and it's thought to be reversible in most of the cases once you stop the Herceptin. So let's talk a little bit about the anthracyclines briefly. This is work that was done by my former chief of cardiology at MD Anderson, and now he is involving a molecule, Topoisomerase II, as the culprit for the toxicity in these patients. What he thinks is that when you give the anthracycline to your patients, you are going to end up causing the formation of ternary complexes. The anthracycline, this molecule, the topoisomerase II beta, and DNA, that leads to fragmentation of the DNA and cellular death. What is interesting is that apparently the possibility of you developing this condition is genetically determined, whereby if you are born with very high levels of this molecule, of this topoisomerase II beta, once you give anthracycline, you're going to be forming a lot of these ternary complexes. While if you are born with very low levels of this molecule, you can be giving a lot of anthracycline and you are not going to be going in trouble. So that's for the anthracyclines. For the Trastuzumab, it's actually a very ingenious therapy. It's a humanized monoclonal antibody against the HER2 protein. And as you can see over here in the screen, the antibody comes and binds specifically to the receptor. Nevertheless, what is interesting is that this receptor is also located on top of the cardiac cells, and it ends up causing trouble. From the primary care perspective, probably the most important thing that you need to remember in these patients is that this antibody blocks this RB2, RB3 receptor that is the pathway that generates what we call ventricular arterial coupling. And the term may sound complicated, but all what there is the ability of the heart to adjust a structure to changes in load. Let me translate it into layman English. It's the ability of the heart to develop hypertrophy when you have hypertension. So as a result of that, the worst thing that you can do to a patient that is receiving cancer treatment and that is on Herceptin is to allow the patient to be hypertensive, because this heart has a complete inability to adjust to the increase in blood pressure, will not be able to generate hypertrophy to compensate for the increase in blood pressure. Now, I told you before that the real trouble is when you combine the anthracycline and the Herceptin. Let me go to the next slide. Very good. So this is the combination, and this is the initial paper that came in the New England Journal of Medicine, showing that the medication really works, but that when you combine it together, as I showed you before, you are going to end up coming with a rate of toxicity of 27%. So it's very interesting because actually this pathway, the pathway that is blocked with the Herceptin, is actually the same pathway of survival of the cells once you injure them. So what the oncologist does is they go and they give the anthracycline initially. The cells are trying to repair themselves through this cascade, and then they go and they administer the Trastuzumab. So you are causing the injury, and then you are leaving these heart muscles unable to repair themselves. And as a result of that, this is when you see the rate of toxicity of 27%. So how is that we recommend in the consensus that we evaluate these patients? And I'm not going to spend a lot of time with this. What we concluded is that whenever possible, and if you're in a lab that has 3D capacity, this should be the modality of choice. If you have difficulty seeing the heart, you can use contrast, and that is recommended. And initially, you need to do the best calculation of ejection fraction that you have available in your echo lab. And we also recommend a strategy of early detection of toxicity. And then we present two alternatives in this expert consensus. If you are in a center like the main campus at the Cleveland Clinic, where we have this technology called a strain, and I'm going to mention a couple of words about it so at least you get familiar with the concept, we recommend that we use it. However, if you are in the periphery and if you are in a center where they don't have expertise on this advanced echo modality imaging, you can use biomarkers, and the one that can be used is troponin, okay? Why troponin? Because if you are killing cardiac cells, if you're causing apoptosis, you, just like in coronary artery disease, your patient is going to be spilling troponins. If you measure troponins in these patients, it means that these patients are having evidence of apoptosis, and then you can recognize it, and then as a result of that, you can intervene. So in the case that I show you, we did what the consensus said. We evaluated a 3D. The ejection fraction was 65%. Couple of words about detection of toxicity. We are recommending the use of a strain, and this is how it looks. It's actually an advanced echo modality. What we do is we use exactly the same images, but we apply a different software. The only thing that I have to say is I have to make you familiar with the normal values, because you're going to see it in our echo reports. What is normal is more negative than minus 19. So say, like in this particular case, we started with a strain of minus 25. This is good news. What is not good news is to start with a value that is lower than minus 16. So for instance, if you see in the cardio-oncology report that I tell you that the strain is minus 8, you know that this is not good, okay? Okay, so we covered the normal values. And why is this important? This is important because we were able to demonstrate that with the use of this technology, we can identify very early the patient that is going to go in trouble down the line. In a recent study, we were able to prognosticate 1 year in advance, when the patient had just finished the anthracycline, when they were ready to start the Herceptin, the patients that at the end of therapy were going to have a reduction in their ejection fraction. So it gives us a window of opportunity because we recognize the trouble so early, where if we start heart failure therapy, and what we do is we start beta blockers in these patients, we can kind of abort the progression to the reduction in ejection fraction and to the development of the syndrome of congestive heart failure. And there are two ways in which we did it. We say the ideal situation is to have a baseline echo, and I'm going to compare the patient to herself when the patient started. So I told you that more negative than minus 19 is great. So if the value during therapy falls below minus 19, this tells us that this patient is going in trouble. So just remember this. The other possibility is we compare the patient to herself at baseline. We don't use an absolute cutoff, but we use a relative drop. And I'm going to show you an example in a second as to how we calculate it. And in this particular case, we figure out that a percentage change of more than 12% is what correlates with trouble. So in this particular case, at 3 months, we brought the patient back. Remember that this is somebody that was just getting Herceptin. The ejection fraction has fallen from 65 to 58. So what we did is we did the strain, and we realized that we had started with minus 25.5, which, as I told you, it's pretty good. In this particular case, it had fallen to minus 19. So this is how we calculate the percentage change. In this case, it's a drop of more than 25%. So this is pretty significant drop. And we are following the algorithm, as you can see, and we are coming up with the conclusion that you have evidence of subclinical LV dysfunction. So like I told you, what we are doing then is we are moving the patient from stage A, which is what the ACC/AHA guidelines will tell us that every patient that is receiving chemotherapy should be classified as, to stage B, which is somebody that it's not just a trouble or a jeopardy of going in trouble with these medications, but who is demonstrating evidence of structural heart disease, and we gave beta blockers. And let me show you what happened. And this is our data showing that it works. So this is what happened. You have normalization of your strain. So remember, this patient has not had any drop in ejection fraction. The patient is happy because they're able to continue the therapy. The oncologist is very satisfied because we have not interrupted therapy, which actually happens in the United States in 17% of cases because of concern with cardiotoxicity. And to the best of our knowledge, right now the ventricle is looking pretty good, and we are aborting the progression into a drop in ejection fraction. Just to finish up, let me show you this case. This is a case of radiation. This is a patient that was sent to me. She's 58 years old. She was recently diagnosed with breast cancer. The oncologist wanted to do a mastectomy, but we have some trouble. And the problem is that she had history of Hodgkin's lymphoma before. She had received radiation. And in the evaluation that was done 2 years ago, they end up coming up with the conclusion that she had severe aortic stenosis. So then the question is, what do we do? The oncologist and the breast cancer surgeon was asking us, can she have the breast surgery first and then the chemo and then the radiation, or do we need to fix the heart first? And you know what is the answer? We were concerned about the fact that she was actually having some drop in blood pressure with stress. So we didn't feel comfortable letting her go and have her surgery. We decided that we needed to fix the heart first. We did an extensive echo, and we ended up coming up with the conclusion that she had not just severe aortic stenosis, she also had severe mitral stenosis. So we actually consulted one of our cardiothoracic surgeons, and they had to go and do replacement of her aortic valve, replacement of her mitral valve in preparation to do the surgery for her breast cancer. Let me share with you just a couple of words about the expert consensus. This is a document that has already been published. It guides you as to how to do the evaluation and what are the things that are important in patients that have received radiation before. This is what I want to share with you. The problem is that the real and the precise prevalence of this condition is unknown. Most of the data that we have is actually retrospective from single center using all techniques of radiation, which are not the ones that are offered right now when you send us patients that have breast cancer, for instance. What is interesting is that right now 40% of cancer survivors are actually 10 years post the radiation therapy, so they are going to be showing up in your offices. And what we do know is that the gain in life expectancy can be compromised by increased morbidity and mortality. So as a result of that, the recognition of these morbidities is extremely important, and these patients are going to be going to your offices first. These are the risk factors. These are the things that are important to ask the patients. Of course, radiation that was given to the anterior or the left aspect of the chest, a cumulative dose of higher than 30 gray, the fact that they received the treatment when they were young, presence and extent of the tumor next to the heart, the lack of shielding, the administration of chemotherapy at the same time, and the common cardiovascular risk factors. The problem is that when you see these patients, it's not just the fact that they receive radiation, it's the fact that the behavior after radiation doesn't help. A lot of them don't pay attention to their diets, are completely inactive. A lot of them are actually involved in heavy substance abuse, smoking, and alcohol, and these are all things that you need to ask. You have over here the relative risk, and as you can see, it's very important for Hodgkin's or for breast cancer. The rate of ischemic heart disease, the radiation-induced heart disease, and the cardiac death is pretty compelling. But let me just show you this nice summary as to what are the things that you gotta think when you see a patient in the office that has received radiation in the past. The damage can be at the level of the pericardium. A lot of these patients could end up developing constricted pericarditis or having pericardial effusions. You have damage of the muscle itself, and we are actually using this same technology that I showed you before, a strain to tease out if there was evidence of damage or not. You have damage to the valves. They can present with either stenosis or regurgitation, as it was the case for our patient with severe aortic stenosis and severe mitral stenosis, and they're going to be presenting also with coronary artery disease, accelerated atherosclerosis, young age, usually compromising the proximal aspect of the vessels. So with that, I want to close. I just want to emphasize to you that these patients are coming to your offices, and it is very important that you recognize them, that you ask yourself, for the patient that has received chemotherapy, have we had a recent evaluation of ejection fraction? For the patient that have received radiation, do I have evidence of any of these things? Damage to the pericardium, damage to the muscle, damage to the valves, or evidence of coronary artery disease. When in doubt, and if you are concerned about your patient, give us a call. We will be happy to take care of it.